Good morning. We'll spend the next 35 minutes or so talking about liver ultrasound. You guys probably did this at the beginning. I wasn't here at the very beginning. How many people are beginners at ultrasound? Okay, so a handful. How many are experienced at ultrasound? All right, so the rest are in between, huh? Okay. All right. So I have nothing to disclose for this talk. Here are the things that we're going to cover this morning. The first is a little bit about the basics of liver anatomy and the Brisbane terminology. We'll go into the three-dimensional anatomy of the liver, talk about normal liver ultrasound and how we use landmarks to identify the liver anatomy, and then talk a little bit about some variants that you'll see. And then finally, we'll show a couple of images of pathologic findings in the liver. So this is Ellen's mentor many years ago that talked about ultrasound and liver anatomy. So Dr. Bismuth, as you probably know, along with Dr. Bloomgard and a few others, are some of the originators of modern surgery of the liver. And they used ultrasound early on in their practice to develop the field. So I'm just going to start with the segmental anatomy of the liver. As you can see here, and hopefully everybody knows, the liver is divided into 8 or 9 segments, depending upon how you count segment 1. The liver has a right half that has 4 segments and a left half that has 3 segments, and those are delineated here, and we'll go into this in some detail as we work through the next couple slides. Again, if you look at the right side of the liver, the segmental anatomy is defined by the portal triads. On the right, you can see the anterior sectorial portal vein supplies segment 5 and 8, and the posterior segment 6 and 7, and that's denoted 5 and 8 here, 6 and 7 here. And then on the left side, as I think everyone appreciates when you're operating on the liver, the left portal vein has a long transverse portion that runs at the base of segment 4. That's this portion here, and then there's this a portion that looks like it ascends into the umbilical fissure that then divides into segment 2, 3, and 4 branches. So back in 2000,
I'm just telling them to close the door.
Okay.
That's all, sorry.
Back in 2000, the IHPBA put together a terminology committee to try to codify liver terminology because it was very confusing in the literature. Based upon those recommendations that were approved at the Brisbane meeting in 2000, they came up with what are the so-called Brisbane terminology. So there's the so-called first order division, which is shown here. So it divides the liver into the right and the left hemilivers. Here's the terminology here for those of you that are that use Quino segment terminology. That's segments 5 through 8. Left hemiliver segments 2 through 4. And then you can see that when you do an operation, this is a right hepatectomy or right hemihepatectomy, left hepatectomy or left hemihepatectomy. If you then look at the second order divisions, we're now looking at sections. 5 and 8 is the right anterior section, 6 and 7, right posterior section, 4 is the left medial section, and 2, 3 is the left lateral section. And then these are sectionectomies based upon this terminology. Alternatively, this is a little bit difficult to read, alternatively, the liver can be divided into sectors. So the right anterior sector, 5 and 8, that's the same as we showed here, the right anterior section. Same thing for the right posterior section, or sector and section are the same. The left medial sector is not the same as the left medial section here, which is segment 4. You can see that The left medial sector includes segments 3 and 4, and the left lateral sector is segment 2 only. And then finally, the third order divisions is what everybody knows as segments, and that's shown here. And again, the terminology is single is a segmentectomy, 2 is a bisegmentectomy. And we'll go through the anatomic landmarks on ultrasound that help distinguish these different portions of the liver. So as a general rule, the liver's size is about 15 centimeters, measured in the sagittal plane in the right midclavicular line. The echogenicity is greater than that of the kidney cortex, as I'll show you in a moment, and that's based upon looking at the adjacent right kidney. If you compare it to the spleen or the pancreas, it has less echogenicity. So this is an example here of the liver, the right kidney here, and you can see the cortex, and the liver has more echogenicity than the adjacent cortex, and this is on intraoperative ultrasound image. A couple of important things to know about the vascular structures in the liver. Portal veins typically are thick-walled, and that thick wall is really Glisson's capsule as it envelops the pedicle and goes into the liver with the pedicle, and that's seen here in these sort of echogenic, what looks like a wall around the black spaces, which are the vessels, and that's really the fibrous tissue that's echogenic compared to the vascular structures. Alternatively, the hepatic veins really look like black holes in the liver, so they almost have no wall that's visible at all. Very thin walls here, and that's how you can distinguish the two. Now, when you're in the substance of the liver, it is hard sometimes to know which is a hepatic vein and which is a portal pedicle, dependent upon how you have the probe positioned. So if you have a somewhat tangential view, a hepatic vein can have a thicker appearance to it, and the way to figure that out is to follow it to where it either comes from or where it goes, and that'll help you distinguish the portal structures from the veins. This next portion, we're going to talk about these vascular structures and the intrahepatic structures and how we can use them to distinguish the different anatomic areas of the liver. The last piece that I have here is that really this is all about pattern recognition. The only way to learn this is to look at a lot of pictures and do a lot of ultrasound. And once you understand the relationships and how they look, you'll find that this becomes pretty straightforward. So the pictures that I'm going to show are some fairly prototypical images that we'll see today on both the transabdominal as well as the model. And this is not how everybody looks, but these are images that we've selected to try to give you some of the prototypical images to help you understand where you are in the liver and to begin to learn ultrasound anatomy. So this is how most of us start, looking at the hepatic veins to begin with. And we'll talk about a systematic approach in a few slides, but this is the vena cava here, left hepatic vein, middle hepatic vein, and the right hepatic vein. And so when we're teaching this at our own institution, what we talk to the residents about is we're looking for the rabbit ears, and that's what the left and the middle hepatic vein look like when they're coming down into the vena cava. You can see here's a Doppler image showing flow in the vein. So this is a pretty prototypical image at the superior border of the liver, looking at the hepatic veins. And then just based upon this and the pictures that I showed you, you can begin to see the different areas of the liver. So to the left of the left hepatic vein is going to be your segment 2 and 3. Between the left hepatic vein and the middle is going to be segment 4, the right anterior section and the right posterior section based upon its relationship to the right hepatic vein and the middle hepatic vein. This is a intercostal scan using a specialized probe called a phased array probe, and it essentially has a very small probe tip, but it has a large pi sector footprint, if you will, and allows you to look between the intercostal spaces to get an image. And so you can see here is the liver. This bright line is reflections off the diaphragm, the vena cava at the top of the liver, and you can see the right hepatic vein shown here. The next series of images will have the external image. If you Keep an eye on these when we do our ultrasound a little bit later this morning. You can get some sense of how to make these images yourself. So this is a sagittal image. You can see here in about the right mid-clavicular plane. And this shows an image of the plane between the right and the left liver. So here's the gallbladder. Here you can see the middle hepatic vein, and that gives you an idea of the division between the right and the left halves of the liver. Moving a little bit more towards the midline, you can see the vena cava here, a cross-section of the portal vein, so the transverse portion of the portal vein, or where it's coming up into the umbilical fissure, and then the left hepatic vein here in a sagittal view again. So just a brief review, portal veins on the right, as we mentioned, the right anterior goes to segments 5 and 8. The posterior goes to segments 6 and 7. On the left, there's the transverse portion. The first branch off the left goes posteriorly, and that goes to segment 1. And then you have the ascending portion of the left portal vein that then gives branches to segments 2, 3, and 4. And again, variations for the portal vein are relatively uncommon. We'll show one of the more common examples of that. Variations in the hepatic veins are more common, and the arteries more common than that. So again, just to review, main portal vein, we're looking at the right side now, so the main right branches into the right anterior and the right posterior sections or sectorial branches, and then the inferior right anterior goes to 5, the superior goes to 8, and on the posterior branches, inferior goes to 6 and superior goes to 7. On the left side, again, main portal vein, here's this transverse portion that runs at the base of segment 4. It comes up into this ascending portion of the left portal vein that then gives off branches to 2, 3, and 4, and the first branch that comes off, as we'll see in a few images and you'll see in our models, is the segment 2 branch coming off. And then just before the portal vein terminates, you see the segment 4 and segment 3 branches coming off. This is Ligamentum teres, which is another structure that you can see well under ultrasound. I'll show a few images of that, and you can follow it into where it looks like it attaches to the portal vein, the remnant embryonic structure. So again, here's a transverse view in the upper abdomen, and this again shows a pretty prototypical view of the hilum. So you can see the transverse portion of the portal vein here, the ascending portion of the left portal vein. If you use your imagination, it's a tree with branches, or it's a ballerina with arms and legs, but this is the segment 2 branch going out here, segment 3 and segment 4 branch. This is a pretty prototypical, so again, in terms of pattern recognition, this is one of those things that once you see it and recognize it, it'll stick in your brain and you'll know where you are when you're scanning. If you slide the probe towards the patient's right, you'll come off the main portal vein, which is here, and you'll begin to see the branching into the anterior pedicle and the posterior pedicle shown here. And then we'll see some images in this space here. You'll see the right hepatic vein. So again, if you have that mental model of the liver anatomy that I showed at the beginning from the pictures, you'll begin to be able to reconstruct in your mind where you are and be able to localize lesions as well as define segmental anatomy when you go to do any sort of resectional work. So keep an eye in this area here on some of the other images. You'll see a black hole, which is the right hepatic vein. If you move further to the right, you can see the branching of the right anterior and posterior pedicle. So if you can imagine, if we were more central in the liver here, we'd see the right anterior pedicle here. As we move to the right, it begins to branch into the superior branch, which goes to segment 8, and the inferior branch going to segment 5. Likewise for the posterior pedicle here, which anteriorly goes to segment 7, or excuse me, superiorly goes to segment 7 and inferiorly goes to segment 6. If you look at a sagittal or a coronal view, so again, this is intercostal scanning here, you can see the gallbladder shown here, and then again the branching of the anterior pedicle segment 8 going superiorly, segment 5 will come and come back this way into the inferior portion of the liver and provide artery and portal vein supply to the segment 5. On the left side, as I mentioned, you can see this, again, looks like a tree with branches or a dancer, if you will, ascending portion of the left portal vein. The first branch coming off is going to be segment 2, and then the segment 3 and 4 branches come off at about the same level as you scan up the left portal vein before you get to where it attaches to the falciform ligament. Sagittal view of the left lateral segment. Again, this is the heart here. You can see a little bit of the diaphragm right here, and a longitudinal, or excuse me, a sagittal view of segments 2 and 3 with the left hepatic vein present on this image. So we're going to move to intraoperative ultrasound, since that's what most of you will be doing. It's really important, and probably has been emphasized already, that you need to develop a systematic approach to this. And the couple issues why, if you do the same thing every time, you'll develop the so-called muscle memory. It'll become automatic, and you won't miss anything. So if you do this in a regular fashion, you'll be sure that you've identified all the important intrahepatic structures, as well as seeing all the segments, particularly when you're looking to do resectional work and identify lesions that you need to treat. And we do that by using the vascular structures that I just showed you in the liver to help delineate the segmental anatomy. And again, this is just a written out version of this, but as I said, most of us do this by beginning with the hepatic vein. So we'll scan at the superior surface of the liver first, identify the hepatic veins, then we'll identify the portal structures. That allows you to really understand all of your segmental anatomy. And then finally, the last part is doing a systematic scan of the parenchyma to make sure that you've seen any parenchymal lesions in all of the segments. So to begin then, there are a couple ways to get to the dome to look at it. If you look at the probe placement here, if you follow the curve of the liver, so if you put the probe and do probe contact scanning, you will not see the hepatic veins in that sort of rabbit ear configuration that I showed you, because you can see that the direction of the beam is actually in this direction if you follow the curve of the liver. So there's a couple things you have to do to figure out how to see this part. One, you can do a probe standoff technique, so you can do an underwater technique where you scan through saline as an acoustic interface, so you can really see this area of the liver here. Or if you take and you compress the liver so that you turn the beam to the direction of the hepatic veins, you can get a good view. And you can see the acoustic window here. You can get a nice view in both transverse and longitudinal sections of the liver here. So again, this is what you're looking for. Here's the rabbit ears, the left and the middle vein, and their common trunk coming into the vena cava. The right hepatic vein here, I think as everybody probably knows, the right hepatic vein typically runs in the plane of the floor or the table of the patient, so it's in a parallel plane to the floor. Here's a different view of it again, left hepatic vein, middle hepatic vein. This is a vein that is typically present here. It goes by a lot of different names, but it essentially drains segment 4. Most commonly, it'll enter the left hepatic vein. It can also enter the vena cava or the middle hepatic vein, often preserved and drains segment 4 if you do a hepatectomy and take the middle vein. This is a view of the central porta. So again, a prototypical view of the main portal vein here. You can see the IVC back here, so you know this is going to be segment 1 here. And there are a couple structures to pay attention to. So first of all is the main portal vein. You can see the beginning of the transverse part of the left portal vein. You can see the right portal vein here, and it's beginning to branch into the anterior and posterior sectors. You can see here both bile ducts and hepatic arteries. So these are probably the arteries here, and this is probably the bile duct right at the top of the hilum. You'd have to do Doppler here to figure out which has flow and which doesn't. And then This is a typical configuration where the middle hepatic vein sits right over the central porta. So again, if you get this image, you have a pretty good idea of where you are. You can see the right and the left hemilivers, and it's a good way to start the portal vein portion of your scanning. So if you then move the probe, slide the probe to the right, again, you can see middle hepatic vein here. You can see the right portal vein, and you can begin to see the sectorial or sectional anatomy here, so the anterior and posterior. And again, as you move further out to the patient's right, you can begin to see more of the anterior and posterior veins. And then as you move further out, you'll see the segmental pedicles as well. So this is a good example of that, where on the right anterior, as you move further superiorly and to the right, you can see the segment 8 pedicle. Again, middle hepatic vein is here. As I mentioned, here's this black hole where the anterior pedicle and the posterior pedicle, which is not shown here, this Y, and the hole in the middle of the Y is the right hepatic vein. So again, you can begin to understand where your posterior sector is back here, your anterior sector is here on the right lobe, and then the left hemiliver off to this side here, which you cannot see. Here's the posterior pedicle on the right, and again, you can see the segment 6 branch coming out and going out to the periphery of segment 6. So all this is very nicely seen on intraoperative ultrasound, and you can see the amount of detail is fairly exquisite. If you look at the left side, again, the transverse portion of the left vein is here. It comes up into the umbilical fissure, so this is the so-called ascending portion here. The first branch, as I said, that comes off is segment 2 here. As you follow this further up, you can begin to see some segment 4 branches here. Here you can see segment 3 branch, and here you can see both of them in the same scanning plane, segment 3 and segment 4. So again, pretty prototypical look of the left side. This is another longitudinal view of the left lobe. Again, you can see the heart up here. You can see the diaphragm here. This is the aorta. This is a view of the esophagus, and you can see the NG tube in here. And then this is a view of the left lobe with the segment 2 pedicle going out into this portion at the top of the liver. Caudate lobe is typically best defined by the vascular structures around it. So this is a look over the left portion of the liver. You can just see again the ascending portion of the left portal vein, the segment 3 pedicle coming out here, segment 4 pedicle coming out here. This thin white line is the gastrohepatic ligament. So as you know, that separates the left lateral sector here from segment 1 and then the vena cava. So by using these vascular structures, the porta, this ligamentous structure, the gastrohepatic ligament and the vena cava, you can get an idea of where segment 1 is here. And again, that's shown over here. So right portal vein, left portal vein, again, the middle hepatic vein that sits right over the central porta. Based upon these structures, that this is segment 4, posterior to the porta and anterior to the vena cava then is segment 1 in this patient, and then you can see the aorta as part of this over here. So you can see a very nice series of images and how well you can define the anatomy in these patients. As I mentioned, there are a couple of ligaments that are helpful. Ligamentum teres, so the free edge of the falciform ligament, the embryonic remnant, as you know, of the umbilical vein. And if you scan up the left portal vein as you're coming up and looking at segments 3 and 4, if you continue to scan towards the edge of the liver, you'll see it transition to the ligamentum teres. And then the ligamentum venosum, as you know, is the embryonic remnant of the ductus venosum, and we'll show some images where that lies on ultrasound. So again, this ligament is very echogenic, so you can see there's shadowing here. This is the essentially the falciform ligament, and then the free edge is the ligamentum teres. And again, this is just a close-up view of it. If you follow this back towards the superior border of the liver, you will see it transition into the top of the left portal vein. Ligamentum venosum is right in this area here at the base of the portal vein. So it's this fibrous band when you go to separate out segment 1 along the gastrohepatic ligament. It's that fibrous ligament that runs along segment 1, so it runs right in this area right here, and that's how it's defined on ultrasound. A couple of variants now. So a pretty common, about 20% of patients will have an aberrant right hepatic vein, and it's this so-called inferior right hepatic vein. So again, this is a pretty prototypical view of what it looks like. Typically drains segment 6. It sits posterior to the central porta, and you can see it draining here into the vena cava. So this is a pretty prototypical picture of what the inferior right hepatic vein looks like. This is uncommon, but one of the few portal vein anomalies that we see. Portal vein trifurcation, essentially there's an absence of a main right portal vein, and the anterior and posterior pedicles essentially come in and join together at the main portal vein. And so this is a typical configuration of what that looks like. This is a laparoscopic ultrasound series of images of a replaced right hepatic artery. So you can see portal vein here, bile duct, here's the hepatic artery, and then here's a aberrant right hepatic artery. If you follow it down, you can see it passing posterior to the portal vein, and then you can follow it coming into the superior mesenteric artery. Not a great image, but this is a aberrant left hepatic artery coming off the gastric here, and you can see it running right underneath the left lateral segments here. And then finally, a bile duct anomaly. So here is a right posterior duct. You can see the bile duct here. This is a transverse view using laparoscopic ultrasound. You can see this tubular structure here sitting behind the primary bile duct. If you change your scanning angle and look at it in a longitudinal fashion, you can follow this posterior duct inserting below the main porta up here, coming in inferior to the central hilum. So a few images of pathology. As I mentioned, the echogenicity is typically greater than that of the renal cortex, so that's one way to judge echogenicity. If you look at the difference between normal and cirrhotic livers, normal livers are fairly homogeneous in their echogenicity, and that's demonstrated here, versus the cirrhotic liver. You can see there's areas where they're much more hyperechoic compared to the surrounding liver, so it's a variegated look in a patient that has cirrhosis, primarily due to the fibrous content within the cirrhotic liver. And so that results in typically increased echogenicity because of the fibrosis in the liver. Focal fatty sparing is a common finding that can mask or masquerade as a tumor or a lesion. That's shown here. There are a couple places where you typically find them. They're often near the gallbladder fossa, the portal bifurcation, or along the falciform ligament. Those are the common places for them. And you can often see these areas and you'll see structures passing through them. There's no mass effect, and that's typical of focal fatty sparing. Hepatic cysts, common finding in the liver. Simple cysts, I think, as you know, essentially have no wall. And if you were trying to decide if this was a hepatic vein, for instance, simplest thing to do is scan above and below or side to side, and you can see that it's a round structure and that it's not a longitudinal structure, identifying it as a anechoic, thin-walled lesion, which is typical of a cyst. And then you can see that there's enhancement posteriorly because there's nothing to block the sound waves, or they travel better through water than they do through the surrounding tissue. Biliary cyst adenoma has quite a different look. Biliary cyst adenomas typically have a visible wall. You can see papillary projections, you may see nodules, you can see septations, and that's typical of a so-called complex cyst, by definition, a biliary cyst adenoma. Liver hemangioma is also common findings. These tend to be hyperechoic. They're very well circumscribed, and when they're small, they're compressible. So if you do compression on one of these lesions and it disappears, that's a typical finding of a hemangioma. If you have a very large hemangioma, they do not have this typical characteristic of well-circumscribed, homogeneous, hyperechoic. They can be variegated in their appearance, and that mixed echogenicity is due to the larger size, but also they can have areas of thrombosis and fibrosis within the hemangioma, giving it a different look versus these smaller, typical-looking lesions. Focal nodular hyperplasia, if we hadn't marked this would be very difficult to see, but they tend to be isoechoic. Again, well circumscribed, and these lesions are easy to miss, particularly in a fatty liver and a liver that has a little bit more echogenicity than normal parenchyma. Hepatic adenoma can have variable appearances, hypo or hyperechoic. They also tend to be well circumscribed. You'll hear a talk on sampling lesions, so biopsying, so that'll be important in trying to distinguish these lesions. If they don't have a typical ultrasound appearance, or you don't have preoperative imaging that identifies the nature of the lesion. HCC can be very difficult to see. It's typically, as you know, occurs in a fibrotic or cirrhotic liver, so that increased echogenicity can make these difficult to see, and you can see that it's very hard to see a lesion within this image here. Here it's a little bit more evident. There's a little bit of a hypoechoic rim around this lesion here, but you can see that you have to do careful scanning to identify these lesions because they can be hard to see. Metastatic lesions sometimes are well circumscribed, but other times they can have very variable appearance, so you can see that this is more lobulated. They also have various echogenic features, and they can range from hypo, hyper, or isoechoic. The nice thing about metastatic tumors is most of the time, as you'll see in the next slide or two, they have a hypoechoic rim, so they look like a so-called target lesion, and that helps you distinguish at least the isoechoic ones from the surrounding liver. So here's a view of a so-called target lesion. So you can see a lesion here, and you can see this hypoechoic rim around it, which helps you distinguish it from the surrounding liver. Now this lesion is somewhat hypoechoic to the surrounding liver, so it's a little bit easier to see, but this one is less so, and you can see this hypoechoic rim around it, which allows you to identify it compared to the normal liver. In HCC, you'll often see tumor thrombus, and so the primary tumor is over here. This is the segment 8 pedicle here, and this is the portal vein that has tumor thrombus in it, and then you can see it coming into the anterior pedicle, this tumor thrombus beginning to show inside of a still patent anterior pedicle. It's a patient that's had embolization of segment 4. So you can see all the embolic material in here, how it's expanded the vein, just an example of additional material within a vascular structure in the liver. So just to end, as I said, and you'll hear repeatedly throughout the day, this is all about practice. You have to use the ultrasound probe on all of your cases to get experience. Look at the pictures in the books or other images that you see, because these prototypical images that we've showed is really all about pattern recognition. And then after you understand what you're looking at, develop a systematic approach to looking at the liver, and that'll be sure that you've seen all the vascular structures that you need to, as well as the parenchymal portions of the segments. So I'm happy to answer any questions.
Okay, great.